All right, so hello guys. My name is Rafael Pinto Colmenares, and today I'm going to be talking about an interesting observational study that I found and I'd like to bring into attention. So this is a relatively new cohort study. It's called the Lymphoma Epidemiology of Outcomes cohort study. It's a multi-center cohort, and I've sort of chosen to bring about a like sort of the presentation of the cohort. It's the the letter of presentation of this study. And this paper talks about the design, the baseline characteristics, and also some early outcomes so far. So just to start up, a brief introduction. NHL or non-Hodgkin lymphoma is a neoplasm that affects lymphoid tissues. It can affect B cells or T cells. Around 90,000 people are diagnosed with it annually in the US, and around 21,000 unfortunately die due to this disease. It's very heterogeneous in nature. The disease varies very much. Some subvariants are very aggressive. In some cases, it's indolent. So there's a lot of variability in how it presents itself and also in survival rates. And also, depending on the subtype, these characteristics differ very much. So because of this heterogeneity, there's potential for a lot of missing information. And the authors have mentioned that there are a lot of disparities that have been identified depending on race, on gender, insurance, rural, and socioeconomic status, and how these factors play out into the disease. So for these reasons, they've sort of mentioned that there's limited data, especially about understanding whether these social determinants of health affect the outcomes of lymphoma. They designed this study to evaluate prognosis and survival and promote the identification of these factors. So they want to know whether any of these factors play a role into them uh, developing worse outcomes or into them having lower survival on, or worse prognosis in lymphoma. So they want to know how they affect, they've decided to evaluate some outcomes like event-free survival, lymphoma-specific survival, overall survival, the incidence of second primary cancers, morbidities, and also patient-reported outcomes or self-reported outcomes. Okay, so just to talk about a little bit about the study design, or sort of the most important part, at least for the purposes of this assignment. This study is a prospective observational cohort study. It took into account patients who were newly diagnosed with NHL. They were enrolled consecutively if they were diagnosed with NHL within the last 6 months, and they were enrolled from one of these 8 LEO centers that we see in the screen right there. Um, this study was also based in a previous cohort, which was known as the Molecular Epidemiological Research, which was part of the University of Iowa and the Mayo Clinic Lymphoma Specialized Program. So it has sort of carried over into this sort of broader, bigger, more encompassing study. Okay, so they've decided to collect a lot of data, and I think this is very important when you're dealing with cohort studies. You want to be able to take as much information as you can. They have clinical data, like baseline clinical data, labs, and initial course of therapy. They performed an enrollment questionnaire to evaluate their demographic data, anthropometrics, and medical conditions. They did a risk factor questionnaire to evaluate exposures, baseline historical exposures, dietary patterns, self-perceived health, and social support. And lastly, which I found very interesting, was the pathology part, because for a patient to be enrolled into the study, they had to have a biopsy taken of the lymphoma. This had to be independently evaluated uh, by a pathologist in one of the centers. And once they diagnosed the patient with lymphoma, they performed a classification using the WHO classification to determine which subtype they had. But not only this, but from these specimens, they also took They performed tissue microarrays. They took tumor DNA, RNA, and also blood samples. So there's a lot of potential things that can be used in the future to hopefully draw causal inferences about lymphoma's progression and survival. Right. So about the follow-up, they contacted them every 6 months for the first 3 years, and then annually. If a patient reported disease progression, recurrence, transformation, or second cancer, then their medical documentation was reviewed, or sometimes they would contact the physicians in charge of treating the patients. If the patients were deceased, then the medical records were taken to determine the cause of death, or the cause of death was abstracted from the death certificate, and this follow-up explains the prospective nature of the study. Patients initially do have NHL but do not have the outcomes or the primary endpoints, and then are evaluated in the future. So yes, for these reasons, they performed a data analysis using or with the main objective of evaluating these primary endpoints: the event-free survival of the disease, relapse, disease progression, retreatment, transformation of lymphoma subtype, overall survival, and lymphoma-specific survival. These data were also compared to the surveillance epidemiology and end results registries, which is a big registry that is done in the US to evaluate patients with cancer. So they decided to evaluate or compare their data to that registry to see how it goes or how it works. And also they performed stratified analysis on ages 20 to 64 and 65 to 79. Okay, so now what did they get? What did we get? What are the main results? About the baseline characteristics, we see that 7,735 patients were enrolled from 2015 to 2020. So we see that it hasn't been too long since recruitment went about. 8 academic centers. 56.2% of patients were male. 62 years of age was the median age, with a range that went about from 18 to 99. And then about the ethnic and racial characteristics, we see that 10.6% of the patients are Hispanics, 86% white, and 7% African American. Okay. So about the subtypes, the most common one was DLBCL, or diffuse large B-cell lymphoma. 34.7% of the patients had this subtype of NHL. 21% had a follicular lymphoma, and 8.9% had T-cell lymphoma. Some patients, other subtypes were mantle cell lymphoma and marginal zone lymphoma, which were the other main subtypes of NHL. 28.5% had a normal BMI, 33.9% were obese, 71.6% participants completed the enrollment questionnaire, which I think is a very contentious point. The fact that there's so much missing data, especially with what I consider to be a very important thing, which was this enrollment questionnaire, brings about questions. Not only about this, but also the other one, which is the risk factor questionnaire. Only 58% of patients did or completed it. The thing is, maybe there were some logistical things that made it difficult. I don't know if sometimes they would have it, they mentioned they have it in paper and like electronic devices. But I can see how it can be difficult, especially if you have a patient that you're seeing in a consult, and then you're like, hey, I want you to join. Say the physician says, I want you to join this study or this cohort, but then you have to sort of look for all the information. It can be difficult for them. I understand that, but sort of brings into question, like, why is there so much missing information? They mention these challenges in their discussion. They say that, so, like what I've said before, and they compare it to other studies, and they say that these rates are similar to other observational studies of a similar topic. But still, I think that is a very big missing amount of data. So hopefully this doesn't affect the results of the study in the future or new studies done on this cohort in the future. Okay, so this is sort of a table one, baseline characteristics. So you can see that they have the analysis or the information divided by type of or subtype of NHL, and also the total patients included in the study. Okay, so another point in the results is that they've already got some early outcomes, which I find very cool and very interesting. The median follow-up is around 39 months, which is not very long, especially when you're dealing with patients with cancer. You know that progression is slow and it takes time for the cancer to progress and develop. They've had 2,451 events, 1,492 deaths. And these are the Kaplan-Meier curves about the event-free survival rate and overall survival rate. And I don't want to delve too much into it. I just want to mention that if you see this pink line that is shown in both curves, this one relates to T-cell lymphoma. So by looking at this, and even in this very short amount of time, we can see that T-cell lymphoma has both a lower event-free survival rate and also a lower overall survival rate when compared to the other subtypes of lymphoma. So hopefully that can help physicians and clinicians determine the importance of this subtype of NHL. When compared with SEER data, the LEO was younger, had a younger population. The overall survival rates were lower for DLBCL, follicular lymphoma, mantle cell, and marginal zone lymphoma. However, TCL showed a variable pattern. Okay, so now about the discussion. The study has a few strengths. I like the fact that it's a very big study with a lot of centers, with a lot of patients, and this shows how the population, at least, was very heterogeneous. It had detailed clinical, epidemiological, and patient-reported outcome data. It had a strong classification of the pathology and subtypes of lymphoma using the WHO system. The fact that the primary endpoints weren't only patient reported but also validated using medical records, I think gives the study a lot of strength. Also, I really enjoy this thing where they mentioned that they want to construct like a large repository of serum and plasma and germline DNA and also tissue microarrays of patients so that they can assess genetic serum biomarkers and hopefully in the future potential targets for the treatment in patients with non-Hodgkin lymphoma. So I really enjoy that part. The study also captures key epidemiological exposures like BMI, smoking, alcohol use, physical activity, baseline demographic data, age, things like this that hopefully can be used in the future to evaluate disease progression. However, there's also limitations. The study has some issues, at least in the terms of it being underpowered for rare NHL subtypes. I think this is very difficult to deal with, especially if you're not doing like you're not evaluating all patients in the U.S., which is frankly impossible. So it's still underpowered for these types of NHL. Also, not all participants completed the questionnaires, which I mentioned before, and it's a very contentious thing. Um, you couldn't obtain blood sample from all participants as well. It had a validation of the primary endpoints, but other health reported outcomes were self-reported. For example, in the terms of comorbidities, the patients only mentioned, yeah, I have hypertension or diabetes, but this wasn't always validated using the medical records. So there's a risk of recall bias or self-report bias from the patients. It also had some underrepresentation of patients of older than 80 years of age and Asian and Pacific Islanders. And lastly, the fact that it was an academic setting. You saw that the institutions that were involved in this study are very renowned in universities, and these can all bring about underrepresentation of the community settings. And this, while you might think that, well, it's difficult to deal with this in the long term, the thing is, when you try to draw conclusions, especially, we saw that the patients in the LEO compared to the SEER data had higher overall survival rates. But then you start to think, wait, if these patients are going to these big institutions, these big universities with these very renowned physicians and scientists, then they're more likely to be diagnosed and they're more likely to be better treated compared to a patient that probably goes to a community setting, which uh, can skew the data and can reduce the generalizability of the study results. So this is a potential limitation that also needs to be addressed. So yeah, just to finish up, I know that for the purposes of the assignment, we were supposed to talk about the confounders as well, but this study doesn't really mention adjusting for confounders. They only mention stratification by age, subtype of NHL, and it's still at very early stages with a short follow-up and with recruitment also still ongoing. So what I think happened here, and I don't want to bash them too much or even consider that they need to be bashed about this, is that the study isn't really evaluating whether an exposure is associated with an outcome. The study is just explaining the design, the baseline characteristics, and the early outcomes. So I think that they're not really adjusting for confounders because they're not really evaluating the effect of exposure, the effect that exposure has. So yeah, um, in conclusion, when you ask the question, are the study results valid? I would say yes so far um, because the study is very robust. It has it's very insistent in the way that they want to take their information, and they're just bringing like, hey, this is what we have so far. This is the characteristics of the patients, and this is the events that we've had so far. What I would like to see in the future is how a it's how a new study that uses this data evaluates these risk factors. And I believe that in that case, they do need to do covariate adjustment and they do need to adjust for confounders as well, so that they can draw causal inferences or at least relationships or associations from a risk factor to the progression and survival of lymphoma. So yeah, that's basically it. Thank you so much for your time, and I hope you have a wonderful day. Bye.